Roger, thank you so much for the nice introduction, and Maud and Ruben, thank you so much for inviting me to present our research data at Basic Science Meets the Bone, and I would like to present the data of the role of MMP13 in multiple myeloma bone disease. I hope it's not too late to meet the science. I give my best to entertain you a little bit, but sometimes science can be a little bit dry. Here are my disclosures. So you're all aware that due to our recent novel drugs, the outcome of multiple myeloma patients increased dramatically over the last decades. But what you also know is that multiple myeloma bone disease is still a clinical problem for us, and around 50% of the patients develop fractures or skeletal-related events over the course of their disease. Multiple myeloma bone disease is not only characterized by lytic bone lesions, bone pain, pathologic fractures, disability, and the quality of life. We also know that the lytic lesions usually occur adjacent to the site of the multiple myeloma cells. And this is a nice picture showing you an infiltrate of multiple myeloma cells. And you see the rim of osteoclast doing bone resorption and resorbing the bone beneath the plasma cell infiltrate. That led to the assumption that multiple myeloma and the osteoclast precursors have a tight interaction, that many pro-osteoclastogenic factors secreted by the multiple myeloma cells activate the osteoclast precursors and lead to multinucleated osteoclast. In an effort to identify osteoclast activating factors, we did a cytokine array and looked for osteoclast activating factors. And what we observed to our surprise was that metalloproteinase 13, MMP13, was highly secreted in the supernatant of multiple myeloma cells, in contrast to other metalloproteinases, which were also secreted at a decent amount. So we were asking ourselves, what is the role of MMP13 in bone disease in general, and what do we do with our findings? So just for your reminder, MMP13 belongs to the family of the zinc-dependent endopeptidases, and it degrades the extracellular matrix. It plays a role in the degradation of the matrix during bone development, during repair, but also during tumor metastasis. Interestingly, MMP13 knockout mice have an osteopetrotic phenotype, as you can see here. There is much more trabecular bone in the knockout mice in comparison to the wild type. Also, MMP13 is highly expressed in other osteolytic tumors, for instance, in breast cancer tumors. What was also interesting for us was the role of MMP13 in giant cell tumors. Giant cell tumors are similar to multiple myeloma. They're characterized by pure osteolytic lesions and multinucleated osteoclasts like giant cells. So MMP13 is highly expressed in the stroma cells of the giant cell tumors, and the upregulation induces giant cells that mediate the bone resorption. Vice versa was shown that inhibition of MMP13 in the giant cell tumors really inhibits the development of lytic lesions. So what we did is we looked in our patients and we evaluated patient serum samples for the expression of MMP13, and what we observed was that there was no MMP13 secretion in healthy donors or in patients without multiple myeloma bone disease. But we observed levels or detection of MMP13 in our patients with multiple myeloma bone disease. Also, in the bone marrow of patients, we could see that MMP13 was expressed in the multiple myeloma cells. So based on those findings, next we looked whether MMP13 can induce osteoclast formation, and we all know that the activity for bone resorption in the osteoclast is characterized or depends on the size of the osteoclast and also on the number of nuclei per osteoclast. And what we observed was that there was indeed a dose-dependent increase in the size of the osteoclast as well as a nuclei number. There was no change in the absolute number of the osteoclast. This is a typical pattern what we saw. You see we add MMP13 in increasing levels and see larger and larger osteoclasts. What about bone resorption? For this purpose, we used dentin slices and we cultured mouse osteoclasts on dentin slices and stained the dentin slices for pits, looking for the bone resorption. All the black dots, you can see this is bone resorption. And indeed, there was an increase of bone resorption when we added MMP13 to our cultures. The next question was, what about other metalloproteinases? Maybe that's a general feature of metalloproteinases that they can induce osteoclast fusion and increase thereby bone resorption. But as you can see, all other MMPs, like MMP 1, 2, and 9, were not able to really induce the size of the osteoclast or the nuclei number in comparison to MMP 13. Again, here you see the huge size of the osteoclast when treated with MMP 13, but no change with the other MMPs. So next, we looked for MMP 13 knockout mice, and we used the mouse osteoclast differentiation assay. So we used the mononucleated mouse bone marrow cells, and we could see when there is a lack of MMP 13 in the system, there is a decrease of the size of the osteoclast. When we add MMP 13, we can rescue this effect. And again, the same with the number of the nuclei. There was a decrease of nuclei per osteoclast, which could be rescued when we added MMP 13 to the system. Next, we wanted to know, when we knock down MMP 13 in our tumor cells, do we see a decrease in bone tumor? And for this purpose, we used 5T-GM multiple myeloma mouse cells. We transfected them with a lentivirus encoding for scrambled shRNA or for shRNA for MMP 13. And we used those cells with a lower expression of this MMP knockdown in transwell assays. So that means in the lower part of the assay, we had our osteoclast, and in the upper part of the transwell, we had either medium, our 5T-GM myeloma cells with an empty vector, 5T-GM myeloma cells with a knockdown of MMP 13, or we tried to rescue the effect, and we added MMP 13 to the 5T-GM MMP 13 knocked out mice. What you can see here is, so the addition of the 5T-GM myeloma cells to the transwell increases the osteoclast fusion. When we add the knockout cells, you see that there is no increase of the osteoclast size. And again, we can rescue the effect by adding MMP 13. We saw again the same pattern for the nuclear number. So that shows very nicely that when you knock down MMP 13 in multiple myeloma cells, you reduce the osteoclast formation in co-cultures assays. After those in vitro findings, we also wanted to see whether we can confirm our hypothesis in vivo. And what we did is we used REC2 knockout mice, and we injected either medium into the tibia of the mice or 5T-GM multiple myeloma cells directly to induce tumor growth, or myeloma cells with knockdown of MMP 13. And in a micro-QCT, you can see nicely the destruction of the bone when we injected the tumor cells, and that by knockdown of MMP 13, we can almost restore or gain the intact bone. Here are the data of the micro-QCT, and you can see each time we see bone destruction with the multiple myeloma cells, when we knock down MMP 13, there is at least a partial rescue of the bone destruction. This slide shows you the immunohistochemistry. Again, this is our control tibia. You see the nice trabecular bone here. You see a normal bone marrow, and you see when you inject the 5T-GM tumor cells, there is a destruction of the bone substance. There is a dense infiltrate of multiple myeloma cells, and I think you can also appreciate the lytic lesions or the pit formation here and the large osteoclast. You can see that by the arrow. When we add the tumor cells, knockdown of MMP 13 restores or maintains the architecture of the bone. There is a less dense infiltrate of multiple myeloma cells, and I think you appreciate that the small rim of osteoclast look always normal, and the osteoclasts have a normal size. We also looked for the effect of knockdown of MMP 13 on the tumor growth. There was a slight decrease of the tumor growth, but I think this was a minor effect. So also in accordance with our in vitro findings, we think that MMP 13 has a stronger effect on the bone, but a less strong effect on the multiple myeloma growth itself. MMP 13 is an enzyme, and we were very excited with our findings. We thought this is fantastic. We have multiple MMP 13 inhibitors on the market and clinical trials for rheumatoid arthritis. What about we use MMP 13 inhibitors and we treat multiple myeloma bone disease? So in order to prove that hypothesis, we generated MMP 13 enzyme dead mutants. So we did a point mutation in the catalytic domain of MMP 13. You can see the enzymatic activity of the well type was maintained, and there was no catalytic activity in the enzymatic dead mutant. Looking again for the ability of the wild type and of the mutant MMP13 to induce osteoclast formation, you see no difference. Also, our mutant MMP13 nicely induced an increased number of the nuclei, so that was rather disappointing. So that means that MMP13's proteolytic activity is not required in order to induce osteoclast fusion. We also looked for the induction of bone resorption, and we saw the same pattern. You can see the addition of MMP13 wild type or the mutant MMP13 to bone resorption assays did not really decrease the bone resorption area, also suggesting that we do not need the enzymatic activity for the MMP13-induced bone resorption. In order to prove our findings again, we also used commercially available MMP13 inhibitor. You can see this. We have our control. We add MMP13, you see large osteoclast. Also here, this is the quantification. And when we add our MMP13 inhibitors, there is no decrease in the size of the osteoclast and no decrease in the nuclei number of the osteoclast. So this was rather disappointing and is showing us that it's not that easy. We cannot just use MMP13 inhibitors in order to treat additional bone disease and probably have to develop monoclonal antibodies. But again, we were also interested in the signaling, which is behind the osteoclast fusion. And you're all aware that rank ligand, when binding to pre-osteoclasts to the rank receptor, induces a fusion of mononucleated osteoclast to a multinuclear osteoclast, and DC stamp is upregulated. And looking for the effect of our MMP13 wild type and enzymatic dead mutant, we saw indeed that DC stamp is upregulated. Also, the upstream signal NFAT-C is upregulated, and we know that NFAT-C and DC stem are also regulated by pERK. And you can see nicely that pERK is activated by the wild type, but also by the mutant. And when we use a pERK inhibitor, you can see this is decreased, but also NFAT-C and DC stem. When you look for the size of the osteoclast, again, induction with wild type MMP13 and with our mutant, a total upregulation when we added our pERK inhibitor, suggesting that MMP13 upregulates the pERK NFAT-C DC stem axis, also again independent of the proteolytic activity. So in summary and conclusion, MMP13 is highly expressed in multiple myeloma cells, not in all, also not in all cell lines. So I think that probably that might give us some hint whether certain patients who have high expression of MMP13 might have more bone disease. MMP13 induces osteoclast fusion and bone resorption activity. I showed you that it induces the pERK NFAT-C DC stem axis, which is independent of its proteolytic activity. And last but not least, MMP13 mediates the bone resorption. What are the future plans? So right now we are about to screen for MMP13 binding partners. Our plan is to extract, for instance, pre-osteoclast cell lytes, incubate them with MMP13 flecked histag, incubate those proteins, do a pull down and look for mass spec analysis to see what are the binding partners. Those is kind of, right now our work in progress, and it's probably too early to really give you a final answer, but I hope over the next 6 months we will have an answer for this. And last but not least, I hope that my team, at least a few of them, are still here. That would be great. I would like to thank also Stephen Weiss, University of Michigan, and my former mentor, David Rootman, for support in this work. And